Hello, my name is Karyn Goodman, and I'm a GI radiation oncologist, and I'm a professor and vice chair of the Department of Radiation Oncology at Mount Sinai. I'd like to welcome you to the Taking Care of You session of this Anal Cancer Foundation's virtual conference. And I will be giving an overview of anal cancer chemoradiation, both the treatment itself as well as side effects. So I'll start with an overview of treatment for anal cancer, and then I'll talk about some approaches that we've been developing to minimize toxicity. And then finally, I'll touch on some new directions in the management of patients with stage 1 through 3 anal cancer. So anal cancer is quite rare. It only represents about 0.5% of all new cancers in the United States. However, it is rising in incidence over the last several decades. In 2021, there were just over 9,000 estimated new cases and 1,400 deaths. The vast majority of patients have stage 1 through 3 disease, and these patients do quite well with a 5-year survival of about 82% for patients with localized disease, which are about 50% of patients, and 65% for patients with a regional disease, meaning that they have involved lymph nodes. So the treatment for anal cancer actually dates back to the early 70s, when Dr. Nigro, who was a surgeon at Wayne State University, wanted to improve outcomes for patients who were undergoing surgery for anal cancer. And he decided to treat patients preoperatively with chemoradiation, which was becoming more commonly used at that time. And he used the combination of pelvic radiation to 30 gray with 5-FU and mitomycin C, which were 2 chemotherapy agents that were available at that time. What he found was that when the patients went to surgery, those first 3 patients had a pathologic complete response, meaning there was no cancer at the time of surgery, which was quite remarkable. And this study was published back in 1974. So how do we treat anal cancer today? Well, we actually still use the same regimen of, in 2021, from the NCCN guidelines, we use the combination of radiation, 5-FU and mitomycin C, or capecitabine, which is just an oral form of 5-FU. Cisplatin is also used in some places and can be used for patients who have HIV, who have more issues with bone marrow toxicity and decreased blood counts, and cisplatin may minimize those effects. But overall, we have not significantly changed our therapy for anal cancer in almost 50 years. So what have we really achieved in all these years? Well, we have made some advances. First, we've made some improvements in our staging process, and this is again from the NCCN guidelines, showing that we do a very, very thorough workup for patients with anal cancer, including important things like gynecologic exams, evaluating patients with anoscopy, PET, MRI, and very thorough physical exam. And of course, for our patients who are interested in fertility, we always make sure that those patients are counseled regarding the fertility risk. So we have certainly improved our imaging since the 1970s. The introduction of PET scan has really been important in the evaluation of patients with anal cancer. This is just a representative image of a PET scan showing the CT scan in the pelvis, an axial image, and the PET scan lights up to show where the primary tumor here is in the anus, as well as a lymph node here in the inguinal region. This MRI, which is a sagittal view showing a patient through the side with their sacrum here and their tailbone here, their bladder and rectum, you can see down here, this is a large mass in the anus, and it's very well delineated here. PET scans have also been used now for treatment planning for radiation. We typically plan based on CT scans, and this is a CT scan through the lower part of the pelvis, right where the anal canal is, and these are the bones of the pelvis. And you can see it's very hard to tell what's going on here. When we add the PET overlay, which shows the metabolic activity in the tumor, you can see this area where the tumor is, which was not very visible there on the CT scan. So what about new approaches to minimize toxicity? So as I mentioned, we haven't changed our treatment regimen in terms of chemotherapy all that much over the years, but we have introduced the use of capecitabine. And this is a study that we did at Sloan Kettering, looking at comparing the use of capecitabine versus infusional 5-FU with the mitomycin to evaluate whether we could reduce the side effects in terms of the blood counts, the decreased blood counts. And we looked over time, and what we found was that the patients who received the capecitabine in the red here versus those who had mitomycin C and 5-FU, there was really no difference in the overall survival. If anything, the patients receiving the capecitabine seemed to do a little bit better. And this is looking at the patients who had, whether they had local regional recurrences, and there was no difference between the groups. So there was no detriment to using the oral form of 5-FU. But what was even more interesting is that in this group of patients, there was a much lower incidence of drop in the blood counts, especially the white count, the neutropenia. And you can see that patients who had the capecitabine versus the 5-FU had lower percent or lower rates of these toxicities. And that was also important in terms of the treatment delay. So patients who had the mitomycin and capecitabine versus the mitomycin and 5-FU had a much lower rate of treatment breaks and a shorter treatment duration, which is very important in terms of the outcome of the treatment. We know that a shorter treatment time and fewer breaks is associated with better outcomes. We did find that there was a higher rate of skin reaction or skin redness in the patients that had the capecitabine, and we think that may be related to the fact that they received daily capecitabine during the radiation, whereas the 5-FU is only given the first and 5 weeks. So this first and fifth week. So this actually may have increased the radiosensitization of the skin. So we've, in addition to changes in the chemotherapy, we've also made a lot of improvements in radiation therapy. And just as by way of background, radiation therapy works by the formation of oxygen radicals and direct DNA strand breaks. And both of these mechanisms cause DNA damage, which can lead to cell death of the tumor cells, but the normal cells are generally able to repair. So that's why we have a preferential effect on the tumor cells. A newer type of delivery of radiation is called intensity modulated radiotherapy, which allows us to be much more conformal in delivery of the radiation and spare the normal tissues that are at risk for toxicity. So this is just showing a CT scan and an overlay of the radiation dose that's going to here in the anus and the inguinal nodes, and really sparing the normal tissues like in the front where the genitalia are. And here's on the side view with the sacrum here. This is the patient's bladder, and this is where the tumor is down here and some of the lymph nodes, and we can really spare the dose to the bladder there. And there, we did want to look at whether there were any effects of using IMRT in terms of not treating the entire area at risk because it was much more focal. And so this was a retrospective study that we did at Sloan Kettering, comparing patients who were treated with IMRT versus the older form of treatment, which is called 3D conformal radiation, where we treated very large fields and most of the pelvis. And we looked at about 223 patients treated from 1991 to 2010. And this is very early on in the use of IMRT. And what we found was both for local control and for distant metastasis, as well as overall survival, there was really no detriment in outcomes. The overall survival was 90% for the conventional radiotherapy, the 3D conformal, and 93% for the IMRT patients. And the local control even looked a little bit better. So this is the group that received IMRT. There was also a large national study looking at IMRT for anal cancer, and patients were enrolled on the study and received the mitomycin C and 5-FU, and then they received IMRT. All patients received it. It was a single arm study, and they did find that they could reduce the hematologic or blood count toxicity, GI and GU acute toxicity using the IMRT approach as compared to historical controls. Well, is there, can we do this on a larger scale? Is IMRT something that can be delivered across other non-academic sites. So one of the things that we found is that because anal cancer is a relatively rare tumor, there are many facilities that are not seeing this on a regular basis. So they may not be familiar with the drainage pattern of the lymph nodes and sort of the issues in terms of spread of the tumor. So what we wanted to do was evaluate whether the facility volume or the number of patients seen per year impacted on outcomes in patients that were treated with IMRT. And we looked at something called the National Cancer Database. We looked at over 13,000 patients with localized anal cancer. And we looked at patients who received treatment at higher volume centers, intermediate volume centers, and low volume centers. And we found that there was a significant difference in the 5-year overall survival between those groups. And in fact, there was a significantly longer overall survival in the patients that were at higher volume radiation oncology facilities. And we think that's because the high volume centers were more likely to treat with concurrent chemotherapy and less likely to have those treatment delays that I mentioned before that can impact on outcome. So why are we so worried about the delivery of pelvic radiotherapy and using IMRT? Well, the main thing is the toxicity of this treatment. When you're treating the pelvis, there are a lot of important organs in that area, and the radiation can cause acute toxicities such as proctitis or rectal pain, diarrhea, tenesmus, which is feeling like you have to go to the bathroom but you don't, rectal urgency, low blood counts, and urinary symptoms. So we wanted to look at our patients who are undergoing radiation and see if we could improve our ability to assess their toxicities during treatment so we could have better interventions to minimize those side effects. So we wanted to look at whether patient-reported outcome questionnaires could help to guide us in terms of our management of their symptoms. So we looked at patients who filled out these patient-reported outcome questionnaires, as well as physician toxicity assessments on a weekly basis during treatment. And this is what we found. We saw that here were the clinician reported toxicities for all of these side effects each week, and these are the patient-reported toxicities each week. And you can see that the patient-reported outcomes are an effective way to evaluate the trajectory of toxicities during therapy. But importantly, we found that for certain types of toxicities, the patient-reported outcomes were actually better. So things like diarrhea that are very objective things where we can easily report, how many times you've had diarrhea, they're pretty well assessed by physicians or clinician-reported outcomes. Whereas subjective symptoms like pain and proctitis are much better evaluated by the patient. And we get these red bars show that the patients actually reported a higher rate of proctitis. So what is the other thing that is important in terms of the effects of radiotherapy? So not only are there acute side effects, but there are late effects of pelvic radiation. You can get some long-term gastrointestinal symptoms, decreased bone density, and sexual dysfunction. So some of the late radiation gastrointestinal symptoms are related to injury to the cells lining the blood vessels and the connective tissues that can impact on the absorption from the intestines. This is just showing the abnormal intestinal lining that may be a result of radiation effects. And then also fibrosis and adhesions or basically scar tissue that can lead to small bowel obstructions. And some of these GI symptoms can have a variable latency after the treatment. Usually the average is about 2 to 3 years after radiation, but they can range anywhere from 6 months to 25 years. We see abdominal cramping, alternating diarrhea and constipation, malabsorptive symptoms, rectal bleeding, small bowel obstructions, intestinal perforation. And about 50% of patients report their quality of life is affected by GI symptoms. So some of the recommendations for this include a lactose-free diet, adjusting fiber, brat diet, bananas, rice, apples, tea, probiotics, Flagyl, sometimes even oral steroids, and bowel rest if it's quite severe. You can also have long-term effects on patients' bone density, especially in women who are already at risk of osteoporosis. So we do see this decreased bone density or osteopenia in a significant number of patients. And this can lead to insufficiency fractures, even that you can see here is a fracture of the pubic bone. We did a study in rectal cancer patients and found that 7% of patients had some kind of a insufficiency fracture after radiation, usually about median time to 2 years. So this can be in the sacrum, these pubic rami, or femoral necks. And so what can we do to minimize those risks? I usually tell patients to take vitamin D, calcium, exercise, especially weight-bearing exercise is very important. Getting bone density scans, this can be important for women, especially if it's actually recommended every 2 years for women. And also if there's a significant problems with bone density, I refer patients to an endocrinologist or OBGYN for other medical management. Sexual dysfunction can also be a late effect after radiation to the pelvis. For women, radiation to the pelvis, if they're premenopausal, will put them into early menopause, cause infertility and vaginal stenosis. For men, because of the involvement of the groins and the proximity to the testes, you can cause infertility and hypogonadism, which relates to low testosterone. For women, one of the main things that we've used to reduce the risk of vaginal stenosis is to use vaginal dilators. Right now, there's no real standard practice, but generally I tell patients we would use it about 3 times a week for 10 minutes. But generally this is associated with a poor level of adherence. So we actually did a prospective study to evaluate the use of vaginal dilators in patients who had undergone treatment for endometrial cancer, rectal cancer, and anal cancer. And we wanted to look at both the adherence and the efficacy. And we found that for the patients were adherent initially to the use of the dilators, primarily 1 time a week, for quite some time, but by a whole year out, or 12 months, they were not using the dilator as much. We did find that using the dilator did help to improve patients' ability to regain their baseline vaginal dilator size. So this is post-radiation. This is the anal cancer group. Many, vast majority of the patients, actually about 80% of patients, had a smaller vaginal dilator that they could use versus baseline. But with the use of the vaginal dilator, the vast majority were able to regain their pre-treatment vaginal dilator size over time at 12 months. So in terms of follow-up for our patients, it's very important that patients are followed closely, especially for the first 2 years, which is the highest risk of recurrence. So we generally recommend that patients are having a digital rectal exam and anoscopy every 3 to 6 months. I usually do every 3 months for the first 2 years, and then every 6 months until 5 years, and then CT chest and pelvis annually for 3 years for stage 2 through 3 patients. Here are my recommended follow-up schedule that I've been using with my colleagues. We usually have the patients see me in about 6 weeks, and then for evaluation of their side effects and an initial exam, and then at 3 months we get a PET scan and they have an anoscopy after that with the surgeon, and then we sort of alternate follow-up, so they're being seen every 3 months, and then we do annual CT scans. And so in terms of our new directions, there's a lot of interest in reducing the radiation dose to patients. And this is a really nice national study that's open called the DECREASE trial. It's de-intensified chemoradiation for early stage anal squamous cell carcinoma. And they're actually giving a lower dose than the typical 50 gray or even higher for patients with T1 and T2 anal cancers. And that study is ongoing, and we hope that will also minimize the long-term effects of the radiation on our patients. As we've heard already, there's a viral etiology of anal cancer, which makes it a potential therapeutic target. And so there are lots of opportunities for therapeutic vaccines. Some of them are in development already. And just I'll touch on this very briefly because Dr. Ang will be talking about this in more detail, but the introduction of options such as immunotherapy have really been exciting. And here's the 2 cancer researchers actually won the Nobel Prize in 2018 for developing immunotherapy approaches. And anal cancer may be an area where we have opportunities for the use of immunotherapy, especially in the metastatic setting. There is an ongoing study looking at using nivolumab, which is a checkpoint inhibitor or immunotherapy agent after chemoradiation for patients with high risk stage 2 and 3 disease. And so this is an exciting option for patients. It's randomizing patients to nivolumab or just observation, and we'll hopefully get the results of that soon. And finally, just on a positive note, even though the incidence of anal cancer has been rising over the last 20 years, we're actually seeing an improvement in outcomes for patients. And these are the data from the SEER data set looking at 5-year survival over the last 18 years or so. And we can see that for localized disease, that the curve is increasing. So we're getting much improvement since the early 2000s, and also for regional disease, and even for distant disease, we're starting to see slight improvements and a trend toward improvement. So I think we're moving in the right direction. And I'd like to thank all of you for your attention. And I'm very happy to now introduce our 3 experts who come from all different fields, all integral to recovering from and thriving with anal cancer. First, we'll have Alison Romero, PT, DPT, who is a pelvic floor physical therapist with a special interest in recovery following anal cancer treatment. She runs a private practice in the San Francisco Bay Area and is a frequent source of knowledge and valuable advice for the anal cancer community. Next up, we will hear from Ashley Arkema, an NP in Memorial Sloan Kettering Sexual Health Program. She provides care to patients experiencing gynecologic health concerns and sexual dysfunction related to their cancer treatment. It is her goal to make patients feel comfortable and empower them with strategies to improve their quality of life. And finally, Rebecca Gutterman is a registered dietitian currently working at Mount Sinai's Ruttenberg Treatment Center. She provides nutrition-related cancer care to patients with various malignancies, specializing in disease within the gastrointestinal system. A firm believer in food as medicine, she works to help people incorporate healthful eating practices within their current abilities and tolerances.